great. It was very informal. It was us, just checking on each other, right? On where we are, challenges that we face. So very informal. And I missed it because we did have this type of format before, and a healthcare meetup, but we haven't had them in a while. And I do see that the nationwide folks are there. So hey guys. So anyway, so then we wanted to, start. Oh, and we invited Joe just because we miss Joe, and Joe always brings great value to any conversation. And so while we're talking there, we thought it would be good for us to do this again.
Yeah, and the turnout on it has been, it's like much needed, like pent up demand or something. When we used to have these years ago, we would be like 50 is a good number. If we can get to that, then that's like across the nation, we'll get some good stuff. And now we're like, yeah, closing in on like 300. So maybe we should have these more than just once a year,
Right.
or every couple months if there's room. And I mentioned this to you and maybe a few other the speakers too. I sent this out to, this might have been an accident on my part in our system, but a bunch of people were tagged as healthcare, and they're actually at pharmaceutical biotech companies and a little bit outside in the life science space. But there's a good number on the call today. So we thought maybe it would be great if the next one we have, maybe folks from that industry, biotech, would be happy to come online and show what they're up to as a kind of a show and tell. So Claudia, if you want to go back a few slides, I think, to the overall one, and we'll just...
Oops, went the other way.
There we go. So I think this is the way. We might change up the order as needed with the speakers. And I'm going to try to keep, we'll try to keep everybody to like 15 minutes each. And that gives us some room at the end as well, or if there's questions that come in. And I will significantly condense mine if we're running behind. But maybe we'll start with Shrujan, right? From Prisma Health and the Care Coordination Institute, CCI. And then we'll bounce over to Marcelo, who was the first to step up and say he wanted to present and cover an HR workforce use case. And then we have Matt from Advising, who's doing some really interesting work with the NHS. So we have folks from overseas online now too, on PPE logistics, like gloves and masks and all the things that we've heard so much about that are critical to have in your facilities. And then Nate and Melissa from Switch RCM have been maybe flying under the radar a little bit, but I think what they're doing is really awesome, and would like to show you what they're doing with revenue cycle management coming from the Epic space. So they're actually in Madison or nearby as well, which is where I'm based for the moment. And I'm over in Epic's deep space. Not really, but I just really like this background. You have to do like a wide angle camera to try to even get all of the seats, and it's just not possible. So again, thanks everybody for showing up. We are recording it. And if you want to ask questions, because there's so many people, just use the chat and we'll try to find you in the list. If you want to unmute, you can say, hey, I have a question, please unmute me, and we'll find you. Otherwise, Claudia and I can read off the questions as needed.
All right, I'll stop sharing. Pass the ball to you.
Yep, I think Shrujan, you should be able to share your screen.
Okay, so I was going to go over some of the COVID reporting and analysis that we've been a part of at Prisma Health. This has pretty much been my life since March, and I promise I'm the same person, that picture from what Joe showed, but I haven't had a haircut in months now. Yeah, so starting this off, this is the main summary page that we have. If any of you attended the meetup that we had, I think maybe 3-4 months ago, we had an initial dashboard that pretty much got zero adoption. It was the most important thing in the entire health system to figure out how we're doing on these COVID numbers. How's our bed facility numbers in terms of capacity and the number of positive admissions that we're having. And we were having such a hard time just getting that information together and putting it in a format to where our end users, a lot of the physician leads were able to see it and use that in a daily basis. So we went through the difficulty of creating a dashboard for them, and yet they were still relying on these manual reports. Just very consistently, they had these people kind of in the background making manual reports and sharing them and so forth. So what we ended up doing was we created a very just fully tabular page. We used the Vizlib KPI designer and just use that as one full page. So these two boxes you see here were the entire page, and we had it fully spread out, a lot of other metrics. Slowly over time now, as this has been able to evolve, we started adding in graphics, and there's been a lot more comfort with that. These are the key metrics that we're still looking at in terms of what our groups go through. At this point, we're at a place to where this Qlik app that we've made for COVID is the main thing that the executive groups go through during their meetings during the week. So we're really happy about that. This is the most adoption we've ever had with the Qlik app in our 5 years of using Qlik at Prisma Health. So it's been a success in that way, and we're hoping past COVID that that's something we'll be able to continue. But yeah, so I'm sure with a lot of systems out there, everyone's looking at the total number of hospitalized patients, the positives, of course, and also the ICU and ventilators being used in deceased patients. The ventilators have been really interesting. Initially, that was a data point that was very critical, very important, because the idea around COVID was to ventilate the patients early. And over time, clinically, as that decision-making has changed, that's kind of altered the way we're reporting these values as well. We no longer run into a ventilator issue in terms of numbers. So that's one of those metrics where, we're still reporting it, but it definitely doesn't have the importance that it had before. To the right, these numbers are doctored, but it's what we show daily is a census and where we're peaking, the hospital admissions, and so forth. Early on, when there wasn't as much testing availability, we had to pretty much just rely on who's coming into the hospital. There was no ability for us to be able to see what could be occurring going forward. As testing has become more available, and as we've started doing community testing, we've started relying a lot more heavily on what that indicates for us. So if we see higher numbers coming forward to us for the community testing, then that's something we're using as an indicative response of going forward. There might be something in the hospitals that we might see an increase in admissions. But that's the mindset, I guess, that we have is hoping to get into that area first. And using predictive models from the Penn team and a couple that we've had internally. I really wanted to show those. Those are some great graphics that we have, but there's a couple of restrictions that we received. But we were able to implement that in here as well. And those are from the community testing standpoint, seeing demographically how we're doing on that, to being able to use those, the Penn model and another internal model that we've been able to create for predictive testing on our hospital admissions going forward. Those have been the biggest areas that we've relied on moving forward with what to expect over the next month, 2 months. The other area that we've been able to see some growth in is being able to test out different visualizations. So at the bottom here, we have this where it's just variation on length of stay buckets from the difference from the previous day. So I think what's really cool here, so this has been mixed. There's been some people that have been, right away, they're like, no, that doesn't make any sense. We're not paying attention to that. To where others will, take a few minutes, pay attention, look at it, and find the value in it. Because ultimately what this is showing is as we've made buckets for length of stay, you see the from the previous day, the changes that are occurring. So ideal situation being if we're decreasing our COVID-19 admissions, if our census continues to go down, those early buckets will continue to decrease day after day, or just be smaller in comparison to the previous day, because we should be declining. As we see rapid increases on that, I think that could be something else that we pay attention to a lot more, but that would be once they're already in the hospital. Because, as you come in through this area of one of the early buckets, then you'll continue to filter out from the other days. So this has been something that we've been paying attention to a lot more lately over the last month or so to continue to monitor. the later buckets continuing to see some slight increases, but the early buckets being largely drop-offs in comparison to the previous data. And that also gives us a better sense of where our patients are in terms of standing in the hospital to do some sort of forecasting around the capacity of where those patients are planning to be discharged in terms of length of stay. The other, sorry, go ahead.
Sturgeon, like the first pass at this, when we saw this app in March, I think for this one, right, you just had just a histogram of the length of stay buckets. So it was really hard for you guys to catch where patients started to go over into the other buckets, right? So this is where that difference part comes in.
Yeah, it was really interesting. That's a good point, Joe, because it was one of those things where, especially where all this starts off, it was just purely reporting, purely just sharing, almost like trivia, like, hey, guess how many people we have in there right now? But this has moved in a direction to where it's more of, it can help operationally because it helps you understand where we are, and it gives you a better sense of capacity without just being the plain number of, oh, we have 50 beds open. Versus knowing, okay, we expect this number of people to discharge in the next couple of days, when we do comparisons against our average length of stay. So yeah, that's where we want to move more towards, but we all understand with initial adoption, reporting itself is just something to grab a hold of and then slowly implementing more advances in terms of analytics. So that's where we are now, and we're really happy with that, being able to move forward. The other thing that we've added in from the New York Times data is state and local information for South Carolina and national data. This has been helpful because it also consolidates the information to where there's just only one place they can go now to get all this, instead of having to go to our local state websites, which they could very easily do that, but we're carrying pretty much the exact same information. To go over the infections, state, national hospitalizations, and deaths. Very interesting. I mean, South Carolina peaked a little bit later than most other states, and you can see that kind of going on here too with this graph. The other thing, after a meeting with Joe a couple of weeks ago, he pointed out something that could be really helpful that we've implemented in this page. We had the option of toggling between a rate and a count. And initially we were using the same colors for both. There's just, you click on rate and you'll see a rate, click on count, you'll see a count. But we started distinguishing the two to where when somebody clicks on a rate, the graphs themselves are changing with that rate to where people can make the visual connection of when they're looking at a rate versus when they're looking at a count. And that's something that we've carried over into the other pages within the app as well. So that's been helpful. This is a page that usually leads off our slide decks whenever we're going through our COVID updates, because everyone wants a sense of what's going on nationally and within the state. Another thing, so again, couldn't really use real data here, but something we've been looking at a lot more has been using these heat charts on different data points over time, including looking at race with patients that are staying for greater than 20 days or less than 20 days to see what's occurring there. Also implementing to the earlier conversation around testing. So initially, when people would have to come to a facility to do testing, there are much larger numbers, or there are pretty much null numbers on certain minorities. But over time, as we've been able to do drive-through testing, we've seen some increases. But what's been the most beneficial has been community testing. As we've been able to get into the communities, allow more to perform testing, we've seen some increases with these different areas for positive patients just to get tested itself. A big issue was people coming to the hospital after already having COVID, having symptoms for multiple days, when initially, if there is a testing site maybe that they could have gone to a little easier, we could have gotten ahead of that. So I think across the country, there's a lot more going on with getting into the communities to do more testing. And then one last thing we have here was, again, from a great conversation we had with Vizlib about just somewhat around like just the positive news. There's there's a lot put around the deceased patients that are coming out of facilities, but there's a lot of people being discharged as well. And so kind of just the breakdown of, hey, we've discharged this is how many are deceased over the time period for COVID-19. But being able to share that information as well of the number of discharges we have over time, month over month.
So there was a question about that, Srujan, or somewhat around that from Tim. And Tim says, you know, are you looking at outcome metrics? This is one of them, like the discharge type, or outcome variance across the demographics and different treatment modalities. He said like mortality, complications, that type of stuff.
Yeah, there's a lot of things we're tracking right now related to our patients once we were discharging them. And it's one of those things where it's still kind of early, but we're starting to do a lot more around that. And that was some of the stuff we wanted to share was around the some of the patients that had chronic conditions already, how that is, you know, I don't remember two specific ones that we were looking at, but we're pretty much just tracking how this has affected them with those conditions, with those underlying conditions. Some people that come into the hospital have had things under control, maybe like a historic diabetic that's got their A1C under control and so forth. But some of the known long-term issues, or what's being reported right now as long-term issues to COVID, we are reporting that. We're working with a research team at Clemson and USC, University of South Carolina, with our data as well and our findings to continue to track that and report that out.
Very cool.
Awesome. Are there any other questions?
Claudia, did you have one? I saw you moving around.
No, I don't see any new ones.
Okay.
Awesome. Well, thanks for the time, guys. And feel free to reach out if there are any questions or if there's a further discussion that anyone wants to have.
Yeah, there might be some things to sneak in, so we can, if we have time towards the end too, just try to tag it as either Srujan or Prisma, and we'll come back. Oh, a quick question was, you know, where are you sourcing that data from? You guys have Epic in one of your sites. We also have Cerner in the other, do you not?
That's true. So we have 3 different EMRs, Epic, Cerner, and Meditech. And we're actually a Snowflake client. So we're going through Snowflake and then creating the QVDs off of that. So it's been really cool. That's an area that we've actually had a lot of comfort in. With our experience at CCI, we combined over 50 different EMRs across the state of South Carolina. So that was an area where a lot of the work that we've done historically has been really helpful for us in terms of being able to consolidate and normalize this data for the system.
Wonderful. Cool. Thanks for that. I think that's all that I'm seeing. Next, Claudia, you want to introduce Marcelo? I think you two have worked together over the years quite a bit too. He's in many of our different calls.
Yeah, I'm so glad to see you, Marcelo. So
good to see you too.
We're connection buddies, right? That's when we actually see each other.
Absolutely.
From Qlik Health. Thank you so much for presenting today.
Thank you for the opportunity. Yes.
Joe, would you like me to show the slide, share my screen and show the slide again?
I think we're fine. It was either Marcelo or Chung-Sun that were going to share the screen first. So I think
yes. Chung-Sun, go ahead and share your screen while I just give a brief introduction to what we're about to see. And then you can also unmute yourself. Thank you. So, so briefly introduce myself. I'm Marcelo Zotter. I'm the VP of Data Analytics for Qlik Health. Thank you for the opportunity to be here with everyone. And this is amazing to share the learnings. As Joe mentioned, we were one of the first ones to offer sharing this, but about a year ago, Tyler Clough from Tucson Medical Center and Brian Vera from the Healthcare Value Network, I don't know if they're on the call or not, but they were very generous with their time sharing what they've done in the HR space themselves. So now this is our way to give back to the community. Why a healthcare dashboard or an HR dashboard? Because we do a lot of dashboards around outcomes, clinical outcomes, business outcomes, and at times some of the ways to improve those outcomes may not necessarily be in improving processes, in improving clinical standards. There's foundational opportunities within the area that perhaps are not in the process aspect, but they're more in the people aspect. So process itself won't do it. And so we realized that it took us a while to realize that process itself is not sufficient if we have HR issues, if we don't have engagement, if we don't have other signals. So the lagging indicators, the outcomes were not happening. But so this is a way to, on the first phase, be able to see leading indicators that if we see all of the HR leading indicators, pointing to there is a healthy environment, then we can expect that through process improvement type of interventions, then we can see the outcomes to follow. But if we do not have those leading indicators in place and we're not able to see those, then we may be spinning our wheels and not being able to get to the outcomes, or at least not sustain them. That's the reason why, and kind of the foundation of why we're looking at HI dashboard, is to be able to understand before we go and do some process intervention in the department, understand what is the environment and measure the environment from an HR perspective, from a turnover perspective, from an absenteeism perspective. So there's several dimensions on this dashboard, but I just wanted to be brief, and I wanted to introduce our data scientist in the team, Dr. Chung-Sung Oh. She's been a key developer for this application. And so I know that you probably want to see that and not hear me. So with that, I'm going to transfer that to you, Chung-Sung. Can you hear me? And can you introduce the presentation? And before we do that, this is a live presentation. It's not a PowerPoint. So we're not able to show all the details because there's employee information. So we'll touch on a couple of screens, and then we're welcome to answer any questions. Chung-Sung, take it over.
Okay. So the dashboard covers turnover, recruitment demand forecast, internal dynamics such as the transfers, promotion and demotions, workers' comp, employee performance review, organization structure to rebuild the management hierarchy and span of control, and then also employee geolocation. And lastly, employee network analysis to identify vulnerable areas for succession planning. So the first page, we try to tell a summarized story to communicate insights with key indicators, trend, and some elements auto-populated for attention. So at this stage, we create output with a rather simple hard-coded logics behind. As you can see, here we present key data points with graphs, and a key few sentences are auto-populated, but it just may not be enough to qualify as a good data storytelling yet. So ideally, we like to apply natural language generation to improve our storytelling for next step. The next page is our organization captures 12-month rolling turnover rate, as well as last 13 months new hire turnover rate. Here we capture a previous month versus the same month in the previous year, 2019. And then we compare our performance against the national benchmark. Here we use FHA national benchmark. Then we look at the turnover trend and new hire turnover trend. And then we also focus on the bedside nursing job groups, their new hire turnover, and drill down to division, and then we look at the turnover rate by department. And if here we do termination details, breaking down to department and job title, and we look at the termination demographics by their age, ethnicity. And we also look at the bedside nursing, which is a crucial job group that is more dynamic. And they are one of our biggest employee groups in terms of headcounts. So we monitor each month new hires and terminated and the difference between the two. And also we monitor overall a fair positions trend, currently open positions, current vacancy rate and the trend, and compare with the national benchmark. Here we monitor over filled positions trend and those recruitment diversity, looking at by job title, gender, and ethnicity. And We also look at the key job groups, again, bedside nursing, their recruitment trend, ancillary job groups, which includes laboratory, respiratory, pharmacy, and radiology, and then also looking at the supporting job groups. And then we did time series forecasting over the monthly job posting volumes for the next 6-month forecast. We used Facebook profit algorithm here. As you can see, we had a big decrease in the job posting volume from the month of March to June due to the COVID shock, and then spike up for the last few months. And to incorporate this COVID impact on the abrupt changes in this during the pandemic period, we model the profit holiday effects. Additionally, we discovered a decomposed trend and the yearly seasonality. Clearly, we have cyclic patterns here. We have a high volume of job posting in the summer, August, and then we have a low volume in May. And then we also captured employees transfers, promotion, demotions, any changes in FTE changes. A transfer can be changes in department and job titles. So we compare the current month and previous month and just looking at the top 10 department transfers or job title transfers. And looking at also promotion, demotion by genders. Workers' comp metrics are important measures for HR leadership. We get this data yearly and monitor the number of total claims, total cost, and also injury rate, which is the number of injuries per 100 employees. And we compare that injury rate with the national benchmark. We use OSHA benchmark for the injury rate. And also we analyze these metrics by department to be able to identify the units to focus on. And this is the employee overview page showing our workforce diversity and demographics. We're looking at employees by age, ethnicity, their tenure and management levels. We're also looking at the management level trend, as well as overall FMLA trend and the volume by department. And this is geographical analysis for current employees to discover employees' home location by zip code, and also employee distribution by their work locations. So our organization currently has 94 work locations, and here we identify how many employees there each location based on the GPS coordinates, and we calculate their commuting time and distance using Google Distance API. And this analysis was used to answer some of the questions we had for employee retention strategy planning. For example, we are planning to assist the housing or transportation, and the question was where should we target the location to be most beneficial for employees. And also when we are planning to move one unit from one campus to another campus, we identify the overall average increase in their commuting time for employees working in that unit to make sure that the relocation does not negatively affect their commuting time. So this analysis was helpful as we try to understand the impact of the relocation and walk through the change. And also the commuting time will be used as one of the features in the turnover prediction models later. And we also create an organizational tree to map the management hierarchy. These three branches are formed with the direct supervisors and direct report structures. And here we use the D3 dynamic tree layout for the visualization. And further, we also looked at the span of control analysis in this page. So by viewing the average span of control by tree depth, and then number of direct reports by direct supervisors in each tree depth, and broken down by job title for each direct supervisor. So we can filter. So another view was using heat map. We looking at the direct reports by direct supervisor for all the three depths and see any difference, significant difference in terms of a span of control. So HR needed a way to visualize and quantify the span of direct control for nursing leadership positions, for example. So that's how we developed these views, and this will help their standardization efforts on nursing department structure. And then lastly, this shows the employee relationship networks by default over age 60, but we can change the age lower bound limit. So we use this analysis to identify vulnerable chains where both direct supervisors and direct reports are close to retirement. Back to 60. And so each node represents the employee, and the node size reflects their age. So bigger is older. The age size reflects the age gap between connected nodes, direct supervisor and direct reports. Node color is determined by departments, and this is also displayed in the bar chart on the right. So this helped the HR leadership to realize the current risk the organization has in the succession planning. It supports them to identify specific department, specific areas at high risk, and target that areas to develop, implement internal professional development program.
Jung-Sung?
Yes.
So there are a couple of questions about data sources, and then a couple of questions about the storyboard. With respect to the storyboard, some of the questions are about, can you elaborate on how was that built, like what's behind some of those insights? And then can you share about the multiple data sources we're using here?
So yes, first data sources. We have multiple HR-related data sources in silos. For example, hiring data in BrassRing, productive data in Kronos, employee data in Infor and Epic, workers' comp in another source, and benefits such as retirement plan, health planner, in another source. So HR leaders were getting more like an ad hoc type of reports in each area. So we wanted to bring not only HR data, but also other ancillary data such as patient experience, engagement, and safety, and set reports into one platform. Those ancillary data is not brought into the Qlik yet, but that's our next step. Storyboard. This is, again, I mentioned it, we're not using any advanced natural language generation algorithm here. It just, we use a simple predefined logic behind around the key metrics, and just try to auto-populate the sentences, give sentences, data points, and then graphs here. So for example, like we're looking at the trend over turnover rate. It's looking at the slope bubble regression curve. If it's going up, we say change the color red, and then it's upward trend. It's all hard-coded and behind all these predefined logics.
This is actually a practice that we're trying to standardize with all of our applications, especially for our senior leaders. Like, what is the story that the data is telling you on things that matter at the executive level, so that they can understand, they can remember, and very quickly you can tell whether things are going right or they're going wrong on just key selected measures, not everything. But what are the 3 things or 5 things that we want to tell them. And this is the work that an analyst would do, right? Foundational work that an analyst would go and then put together a PowerPoint, put together a few bullet points. So the idea is that let's get that in here so that this is all automatic and then, available at any time. And we try to standardize this practice for all other applications. And that seems to resonate really well with, what is the story? Because our leaders want to tell a story. What is the data that the story is telling so that they can communicate? Not only they're aware, but they can engage through these stories about changing behaviors, improving performance, whatever the case might be. They use storytelling in order to engage. So that's the reason behind some of this. Chung Soon has done an amazing job here, as you can see, creating these visualizations. We also have a data architect that is helping blending data from multiple data sources. And we basically have two resources. We're working very closely with HR. We have data stewards within HR, data analysts within HR that are helping with the validation, and in IT as well, the application stewards for Infor and Kronos that help us understand where the data is. We are wrapping up the development and validation. We haven't deployed this yet, but that's next for us. So I want to be respectful of the other presenters' time. We took 20 minutes, so I'll pause there. Thanks again, Joe and Claudia, for the opportunity.
Yeah, thanks for sharing. Amazing work.
That really is. Yeah.
Lots of notes coming in to everyone, but also directly to me too, so I can see. Lots of good questions coming from that. So we might want to even do a deeper dive next time, Marcelo, and with Chung Sung, and take apart some of these things like those dynamic narratives, and get a read back on when you release this out, and how the managers and directors use this, and how they take the information that is. This is the reality. These are the people that are leaving. These are the ones that have negative feedback and things like that. But also, where's the good outcomes of this? I love the layout. You can basically answer any question you would have about your staff with this.
Yes. Yeah. Everything you wanted to know about HR and more.
Nice. One question that was asked. That's the title of the book. How long did it take you guys to get to where you are right now?
So we've been working on this for, I would say, because we have a COVID pause in between, like 3 months for COVID pause. So I would say we're working on this between 7 to 9 months, working slow on this. We've had several data quality issues, as it data comes from multiple sources and it doesn't come as we expect, and it's not clean. And so this is the first area that we incur in the area of HR. So we didn't know much about the business of HR, let alone the data sources for HR. So the team had to quickly learn just the HR language, right? And what matters to HR, the HR business. And also learn about the systems, what the fields are, and why the data is not coming clean, why are the dates not the way they're supposed to be. HR, it's tricky because you need to have like snapshots in time of how the organization looked, a month ago, 2 months ago. You need to have those snapshots in time, and so it's tricky. It sounds simple, but it's very tricky. And then on top of that, you add data quality issues. So we spent quite a bit of time kind of cleaning that up, and we're still going through that process. So, but it's been really good. The feedback it's great from our HR leaders. They're amazed.
It's fantastic. And there are a lot of questions on extensions, and I know we probably don't have much time, but can you guys give us an idea of what extensions were used that it's outside the box from Qlik?
Chung Sung, can you comment on that, please?
Only that, because we do not have a Vizlib.
I know.
Yeah, only
no, I wish we did.
Is that for the?
We'd like to.
Yeah.
We use the D3.
D3.
Part, yeah, D3, the tree layout extension. We customize a little bit. Yeah.
Everybody's talking about that social network. I think this one that comes up.
Yeah, this is nice.
And I've seen these before, but I've never had a compelling use case for it. So this is a really good use.
Fantastic.
And
So
then
to emphasize
only
that brought
the-
huge value. Sorry.
Yeah.
go
another
ahead.
thing is just Google Distance Map API for calculating this actual employees commuting time and distance.
Yeah.
And only these two things. Other than this, it is all in box we used.
Okay.
Yeah.
And Marcelo, you mentioned it brought huge value. Can you speak to that? Because I'm super curious about how they're using it.
On the dynamic, yes, on that network diagram, the huge value that brought to the organization, they wanted to understand where we may have pockets of leadership relationships that are all approaching retirement age at the same time. Where do we have a succession planning issues? Like where in organization do we have that? And where we may have areas that the whole knowledge may exit the organization without having leaders in place. And so where do we have this network of leaders that are reporting to each other in the same department, that they're all approaching retirement age, that they may leave all at the same time? And so that is huge value for the next 2, 3, 4, 5 years that we need to start planning on. And so, putting that and telling the story about that, making that visual and pinpointing exactly where the issues are, I mean, that was amazing. Our chief of human resources was like, oh my God, this is so good. And by the way, it all started with, I need a heat map. And so his request was, I need a heat map. And so, that a heat map is an analytical outcome. We turn that question into what is the business question you're trying to answer for which you think you need a heat map. You may need a heat map, we'll give you that, but you may need something else. And so understanding the business outcome they're trying to achieve and then identifying what are the analytical outcomes that can help achieve that was huge in that. So that has huge value for organization because it takes time to develop leaders, and so huge value there.
Awesome.
That is fantastic. Incredible.
Thank you for that feedback.
Yeah. Thanks for sharing again. Again, that was really great. I'm going to chop my part really extensively, but there are a few questions people wanted to see of what I had as well, but keep those coming in from Marcelo and Chungsun, and we can get to them at the end. I'm going to share my screen real quick. This is all in progress. Again, as folks know, when I came to Vizlib, I started working on more than just healthcare, which was fun. I'll admit there's different challenges, but I miss healthcare a lot. So as Claudia and others have kind of brought me back into the fold, I'm like, I really want to revisit some of this Epic stuff. And this should look familiar if you've worked with me in the past, Qlik being that thing that can bring together all these different data points. And when I looked at this, I saw, man, all these arrows are just pointing to give Qlik your data and you'll be able to see it. And then what I've been working on lately with Vizlib is, well, what can we do with it now? Let's take action on the data, and we're writing data back now. And I've started to explore the Epic APIs that allow for updating information directly in the EHR, but also I've worked with other EHRs in the past. They also have comparable things. So if you're on Cerner or Allscripts, we can write to those data sources as well in certain cases. And this is opening up some really interesting things. And I've had discussions around, telehealth, as that's just the adoption of that has gone through the roof. And now you're capturing new questions. So we're not going to spend a lot of time on this at all, but if you want to talk about this, please feel free to reach out and I can show you what we're doing. I did also attempt to go back to my roots here and get some Epic hyperspace action going and show some new versions of applications that I've worked on in the past to give you a look and feel of let's bring that application that you spent so much time in and put it directly in the EHR. And so with that and the integrations that Epic allows for, you can have this really rich experience with your data, whether it exists in Epic or outside of it, and have your users interact with it. And that next part of that capability is the ability to launch into patient charts or open up an account And so, yeah, I handed this over when I left Qlik and we're on recording, but there's not a lot of other people that are working on this. So even outside of Vizlib, just happy to help you all understand how these integrations work and jump back online. So I'm trying to be more active on the Qlik community where we talk about Epic stuff. And the last quick thing is there was this app library that I've worked on for years, and I took a new crack at it. And this is, maybe folks are familiar with one of the movies, right? And in Epic's campus kind of looks like Harry Potter. And so I took and created this as a new entry point into the app library. So you click on the sorting hat. I'm not a very big Harry Potter fan, but I'm learning a lot more about it. So the sorting hat gives you the ability to sort through information to figure out what school you're supposed to be in. But here it might be the application that you need. And so we could come in here, we could pick on, say, Lawson as a data source. And oops, I clicked the wrong button there. And we'll see all of the applications that you all have submitted over the years. You know, I've interviewed 3 organizations. There's 8 apps related to Lawson across these different topics. And it gives you the way to just understand what else people are creating. My version I want to update of this will provide some level of contact information so you can go out there and see maybe that Lee Health has created an application on top of Lawson, for instance. I'm not sure if they have, but that would be something you'd have in here. And then have a little fun with how you interact with this. So maybe you just want to browse over how many applications are using this information. So this is still a work in progress, as you see, but I'm having some fun with it to give you more information about what people are building in the healthcare community. So 1,500 apps. And I need help to fill this out with more because I haven't really interviewed anybody in about a year. So if you're interested in getting access to this, I'm going to send this out to the group after I get it published, and we'll continue to add to it as a community. And that's really all I had. I want to pass it over to Matt, and then if he's ready, and he should be a co-host here, and then we'll have Nate and Melissa as well right at the end. So I think I took 3 minutes, maybe 5. But Matt, if you're good to go with 15 minutes or so, I think that keeps us on track.
Great. Thank you, Joe. Thank you for inviting me as well to this opportunity. So it's the first one of these I've joined, so it's great to be here. You can probably tell by my accent, I'm from the UK. And we've started to do a bit of work with Joe at Vizlib on some other right back bits, but we're not actually going to go into those today. I'm going to take you through something else we were doing during the start of the COVID crisis. So just by way of background, I first used Qlik in 2004. So it's been 16 years of using Qlik when it was still a Scandinavian product, and nobody really knew that much about it, but we were having all sorts of challenges with data and pulling data together from various different sources, so it did as well. And 6 years ago we created Advise Inc, and we focus really on healthcare, and we focus on spend data, so anything to do with commercial data, inventory management data, purchase order data, we do all that analysis. And I guess our claim to fame as a business in the UK is we were the first to launch a price benchmarking tool based in ClickView. We had it live in every single healthcare facility across the UK. Over 200 organisations pull in purchase order data. It was about $20 billion worth of spend data at line level, and it basically enabled the NHS to price benchmark every single product they bought. So it stopped suppliers from the J&Js and the Smith & Nephews, and there's 50,000 other of those organisations charging different prices for the same products to hospitals. So they reckoned it saved about $500 million a year just through that visibility. So it was a massive benefit. But then of course COVID hit, and people caring about saving money and where am I next going to buy stuff was less of an issue, and it was, my God, where's the PPE? So all the protective equipment became number one issue, and we said, look, you pay for our tools a year in advance. We're an OEM partner of Qlik. You pay for our tools a year in advance. We will use our time to be more beneficial to you, and we'll do it for free. So tell us what you want to do. And in the first few days, we had an organisation healthcare organisations say we need some help. We're struggling to track PPE. Where is it? How much do we have? How long will it last? Will we be able to protect our frontline staff in ICU? We're doing it all in Excel. Excel spreadsheets are flying around several times a day. The board have lost all confidence in us. Can you help? So it was one of those brilliant case studies, stories for Qlik, where we took the call at midday, and by 5 o'clock they had an app and it was all live and they were using it. So it was literally a few hours. We created a quick Google form, captured stock levels, did away with all the Excel. We then put the Google spreadsheet, just stuck Qlik Sense on top of it, and that was the first version that went live. And within a month, we had 200 organisations using it. So the team worked tirelessly, 7 days a week, as they were doing in healthcare as well. We kind of matched that for free for 6 months. So we worked for free with Qlik. So Qlik provided the licensing for free, and we got that live across 200 public organisations. And I'm going to show you a demo in a minute, so you're not just looking at my face and listening to my voice, and you can actually see the app, which I think it'd be good to share. We also did a load as well around with AI, so we were taking epidemiological data, organisational capacity data from freely available resources to drive forecasts on how much PPE would be needed in an ICU setting, based on how many patients they had in and which way the trend was going, which proved hugely successful in the early days where they were really struggling to forecast the requirement. So without any further talk from me, let me share my screen and I'll show you the process. So in the end, we moved everything out of Google. Google Forms was a bit too open. We stuck it all behind in a Flask app, which is like a lightweight web tool that we basically developed, and it allows organisations to come in. They can select their organisation, tell them which site they're on, where are they sitting, and then they can come down and they can tell us how much PPE they've got. So 3M face masks, the FFP3 masks, got 100 of those, and they'd basically do this each day. They'd come in and tell us how many of these masks. If they were struggling to do the maths because everybody was pressured, they'd just use this little calculator. So I've got 24 boxes with 34 in a box, and just add that to the form. And I'd basically go through and submit, and that was my job done in a storeroom each day. I just had to do it once a day. It would take a few minutes, and then it fed this app. So everybody had access to this, both local organisations and regions. So there was a lot more regional work in the UK when COVID hit. They struggled to source enough PPE, so regions were left to get on with it and sort it out themselves. And basically, we come into the app. I'm zoomed in on Greater Manchester at the moment. We did a lot of work with Greater Manchester as a region, and if you want to know where that is in the UK, it's there, to the northwest. All of this data is made up, I should say. So this is all demo data, just to be really clear. There was a lot of sensitivity from Manchester about me demoing this tool. It's the first time it's ever been demoed outside of healthcare, so nobody's seen this before. But they basically use this to understand kind of where PPE is, who has what. So on the left, I might just zoom in on Chrome so you can see some of these bits a bit bigger. We could look at things like the masks. I know in the US there's KN95 masks, which are the equivalent to FFP2s. So in the UK they went for a higher standard in kind of the aerosol generating procedures. So basically ICU when you got somebody on a ventilator. So I can go into FFP3 masks and I can see where all the FFP3 masks are. I can understand how much stock levels we've got and how many days. So here we've got this particular mask, the 8833s. We've only got 1 day of stock left. So I can drop straight down into it further and start to understand who and where based on their burn rate. So we understood how much they were getting through each day. So we could figure out how many days stock. And all the other kind of, this is all standard sense. There's no add-ons to this. There's no Vizlib stuff in this particular product. So this is all kind of out of the box sense. So I can do that. I can look around. I can see it on a map. There was another screen where not only the organisations then, but I can see kind of trends over time for different products. I can look at it in terms of site, because sometimes the organisations would have 3 or 4 sites with PPE stored at different sites. So when they were looking at delivery, we would map out where all those organisations are, so we can zoom right in and see how much PPE. Again, the size of the circle changes depending on what you select. So we could do all that, and this was used extensively, like we're literally within the back end of March, used by Gold Command in the UK. So for Greater Manchester, they have a command structure for emergencies. The Mayor of Manchester, Andy Burnham, he would tweet about how much PPE they've now got in Greater Manchester, and he was using our stats. So it was out there actually using this tool in all their decision making, to the point where they actually said it saved lives, where one organisation was an hour away from running out of protective equipment in an ICU. They were able to log in, quickly see who had excess using this tool. They sent a police van with the lights going to go and pick up the excess stock and take it to the hospital, literally kind of minutes before they would have had no PPE to protect their staff. And they said in the past that would have been a series of phone calls, it would have been Excel spreadsheets, the data would have been out of date because nobody fills it in on time. So there was all those challenges as well. We're now moving this forward. We've got, it's not actually in this tool yet, but we're now automating various bits. I'll just show you this though as well. We're now automating various bits where the regions are now using this data to push stock out to all the facilities. So based on this data, we can see how many days stock they've got. If they're dropping below 30 days, an automatic order will be generated. We will send them an email saying, do you agree? They can say yes or no. If they say no, they can amend it. If they say yes, it'll just arrive on the Friday. So now the organisations don't have to worry about PPE. It's all fully automated, and the replenishment of it is fully automated. And this is just showing you again, just a different way of showing similar data where we can look at red, amber, green. Red being less than 2 days stock, amber less than 5 days, green is greater than 5 days, and blue's an interesting one. So blue is where they've got a load of a product, but they don't actually use that product. So they're just storing it. So if we needed, like I said, this is all made up, but body bags, because hopefully we don't need 22,000 body bags just in Manchester, but if we did, the ambulance service have them. The ambulance service don't actually use them. It's the hospitals that use the body bags, so we could look at that as well. We're having conversations at the moment out with Australia around bringing this into Australia and other industries, and some of the major logistics firms as well that kind of do logistics on behalf of some of the med techs. They're looking to get into it. So we have now moved to a paid model, because we can't continue to do it for free. We'd love to, but we just can't afford to. So, and Qlik will also want their money for their licenses. So we've moved to a really low cost model, which is basically it pays for the Qlik license, and it's really cheap. So you're kind of $200 a month type territory for our access to all of it, including all of our support. We've got online training. There's various different manuals and guides. So yeah, that's us.
That is great, Matt. And you guys are, you've won some awards and gotten a lot of good coverage, I think, too, from Qlik, luckily. So I think everything that I've seen and heard about what you guys are doing is just amazing. And you have people like David, who's in New Zealand, which is like 5 a.m. there. He's up, he's excited about it. They want it. And, there's a lot of manual work, like you said, that's gone into this, and sourcing of this data. How do you think that this could be something that could work in the US when we have such unconnected systems? There's no one spot this stuff is stored. We'd love to have that type of thing where the hospital down the road, what they have, so you can trade supplies.
Yeah, so it kind of sits somewhere. We always say the tool sits somewhere between doing things in Excel and a full-blown inventory management system, because in your hospital you've probably got Omnicell, or there's some other system where you understand all these products and where they are. But what they found out in the UK is when COVID hit, things like Omnicell and cabinets, the nursing staff just wedged everything open, raided the shelves, and all of a sudden the systems just imploded because they just weren't designed for, they were designed for BAU, they weren't designed for emergencies. So this kind of sits somewhere in the middle where we do away with Excel. It's really lightweight. Any organisation can have it. So we're now talking to restaurants and schools and all sorts, because actually the implementation is zilch because we host everything. You just need to come on some training. You can basically feed the input sheets with very little training. This is all configured by you, so you can say what you want to track. So sterile gloves, latex gloves, aprons, all this is configured by you, so you can just track what you want to track. And then when you drop into the analytics, you are part of a group. You say which group you want to be a part of. So if you're a group of hospitals in San Francisco, you can say we're all part of a group, and we just configure it so you just have visibility of your group. So you wouldn't see the restaurants, you wouldn't see the schools, but as a group of healthcare services, you would see each other. So in the UK, they wanted to stop at the regional level, but we have a national level, so we can see everything across the country. So it's all configurable and dead easy to do, and we have people live within hours. So people say, I want on, and you are live and using it in a matter of hours.
That's very interesting. Yeah, there's questions coming in, like it can be used for other things. I think you just talked about that. So you can load up different supplies, medicines, those types of things, maybe complement what you have in your inventory system. You certainly wouldn't want to replace that necessarily, but you see it more for that connecting to the other health systems and being in that group as being the real value of it.
Yeah, I think so, and that's what the regions have said, is it's that ability to see instantly. So that app I've just showed you refreshes every 15 minutes. We just have it on a 24/7, it refreshes every 15 minutes. So we say it's more or less real time, so you understand what's going on. And it is that regional visibility. If you were just one organization on one site using it, yes, if you've got 30 locations within your site, using this would be great. But you know what, Excel might be an answer, and it might suffice. But as soon as you start getting groups of organizations working together, so if you are a chain of restaurants or you're a group of healthcare providers, this sort of stuff's brilliant, because it's very noddy. There's very little training. Away you go and you get the value. And it removes all that non-value add. I mean, we saw in hospitals the amount of Excel that was flying around. People were taking out, they were removing the security and then fudging all the, like destroying all the formulas, so they would send that in, and then every day the same person had to change all the formulas back again. They were just unbelievable. So when we showed them this, they were just amazed that you could do something kind of the lightweight front end, the way Sense is just near instant with the analytics. Yeah.
And did you find anything that was surprising? Like, we all know about masks, gloves, gowns, vents, those types of things. Were there any, like, people ran out of supplies that they weren't anticipating they'd be running out of?
No, I mean, it did fluctuate. So there was all different things at different times, sometimes due to the national pandemic store that we have, which have been bolstered for EU exit. So coming out of EU, they bolstered it even further. But I think the speed of which that just drained was quite immense. So that was a surprise. But then we also saw then the knock-on impact of other consumables. So we were tracking what we thought were core PPE, but then a lot of the plastic tubing, people asked for that to be added for ventilators and other bits, because it was like the next set of consumables then became an issue. So folk were then wanting to add more and more, and more recently they've pared it back. They've gone right back to a core list for the tool. So at one point we were tracking ventilators, so ventilator availability across regions. So the neighbours to Greater Manchester, Cheshire and Merseyside would track ventilators. So they knew exactly how many free ventilators were available and where they were in case of an emergency. But as it's died down a bit, they're no longer doing that. But then if anybody's watching the news in the UK, and I guess other parts of the world, it's taking off again. So it may well be a case of they start to track those products again.
And are you guys on lockdown again? I know the Manchester region had something. We have some, my colleagues are there.
Yeah, no, there was another announcement today from Boris Johnson around further restrictions. I don't think we're going back to where we started in full lockdown, but they're slowly kind of squeezing different things. All the pubs now shut at 10. Not that I went to a pub, but if I did, I would only be able to go till 10. And some of the sporting events now, they're stopping those. So they were going to reintroduce football games and crowds again, and that's all been canned.
Very interesting. Thank you so much for sharing and walking us through that. We get a preview of that, right? That I don't think many other people have seen publicly. So if there's anything sensitive too for any of the speakers, that we go back and, Marcelo and Chung Sung too, you had some names in there. If I need to blur that out, if we post this recording, I'm happy to do that too. But I love this sharing that's going on. And so keep questions coming through. Matt, you might see some in the chat if you want to respond there towards the end. But I want to give the rest a little bit of time here to Melissa and Nate, my friends just down the road, and have them take you through what they do at Switch.
All right, sounds good. Let me share my screen here. All right, so I'm Melissa from Switch RCM. This is Nate. Just for a quick background on us, both Nate and I have spent over 10 years in the healthcare industry. Like Joe, we got our start at Epic. We were both on the claims and remittance team there. After Epic, we both moved on to product management at Experian Health, which was formerly Passport Health, and then Nate moved on to healthcare IP. Nate continued to focus on claims and remittance, and I moved on to work in the contract management and the patient payment estimates space. And then recently, Nate had spent a few years working in various senior management positions within healthcare operations. We started Switch a few years ago just in hopes to help our customers capitalize on the value of their data. As you all know, there's so much data out there right now, and we really see organizations struggling to capture it and then understand it and then use it in a truly meaningful way. So we designed a few solutions to help with this. Overall, we're a rev cycle management company. We focus on revenue recovery and payment optimization, process automation, and analytics, primarily in the professional billing space. So we've seen that PB is often not a priority for large organizations, just because of the high volume and low dollars that is typically associated with it compared to hospital billing. So even when an organization does have its own analytics department and they've implemented things such as Qlik, their focus is often on clinical applications or on hospital billing, and it leaves professional billing without a good way to really manage their data and their revenue. So we've designed a few products to help with that. One of them is our contract management system. It integrates directly into Epic, allowing for automated contract build and maintenance of the payer contracts directly within Epic. And then we also have products that focus on accounts receivable, charges, payments and adjustments, and claims and denials.
And so one thing I'd add on the process automation is that we are actually feeding data back to Epic that triggers workflow activities within Epic to do things such as resolving small balances that you don't want staff to work. So Joe, you mentioned feeding data back into Epic. That's something we're doing, and we're actually creating the output files right out of Qlik.
Awesome.
All right. So the product that we're going to demo today is specific to professional billing underpayments. So every organization struggles with underpayments. Payers are constantly changing their contracts. Oftentimes, even within your organization, you struggle to get access to even see those contracts. And even if you are provided access, the contracts often come in a PDF format. The PDFs make it basically impossible to automate anything or maintain that automation, even if you do eventually get that set up. And then also, even if you do have your contracts within your EMR system or within Epic, the reporting that's available to either see those contract rates or to get to the underpayments is often not as granular as you often need. And then trying to track down underpayments manually in a system such as Epic is basically impossible. It is incredibly labor intensive. So our current underpay solution tries to take away as much of that headache as possible. So we try to take away the headache of working with your payers, interpreting those contract terms, or waiting on your IT team to help you with something. So our product consumes 837 and 835, so contract and remittance files directly. We can either get those from our customer or we can get those directly from their clearinghouse. If we get them from their clearinghouse, there's actually no IT involvement to set this system up at all. So our system uses that data and applies various machine learning algorithms to this data to determine what the appropriate contract rate should be for the common procedures in your data for your top payers. So essentially what we're doing is automatically determining your rates and then modeling those contracts. From there, we have additional business rules, payer rules set up in our system to determine what the correct allowed amount should be for each of those procedures. And then from there, we calculate, or we compare that allowed amount to what the payer actually paid on the 835 to determine whether it was appropriately paid or if it was a potential underpayment. All right, so Cedars-Sinai is one of our clients that uses this tool currently. To date, they've recovered over $4 million in underpayments using our products, and they're in the process of recovering a significant portion more right now. They also use our products to model all of their payer contracts directly into Epic, and they've estimated it saves in between 1 to 3 FTEs per year. All right, so I'm going to jump actually into our application. All right. The underpayment detection application is a pretty simple application. We have a brief overview screen here, and we do use quite a few of the Vizlib extensions. The extension or the visualizations that you see here are all from Vizlib. So on the right, on the left, I'm sorry, we see just the potential underpayment amount for the organization over time. So in this case, we can see, and again, just like most of the others, this is demo data. So it is based on one of our clients, but it is PHI free, so no worries on that one. So we can see the potential underpayment amount, and below that in purple, we can see the actual amount that the organization has recovered. So we can see that there's about a 25% recovery rate right now at this organization. Below that, that metric is broken down by the contracts. Again, as demo data, we only loaded 3 payer contracts into this application: Aetna, Blue Shield, and Medicare, just for simplicity. On the right-hand side, we can see our top 10 offenders list. So we can see the places of service that are causing the most underpayment amounts in the organization, as well as the top 10 procedure codes that are gathering the most potential underpayments. Below that, the procedure codes are grouped into procedure types. So we can see that we're having some issues with E&M codes and radiology primarily. And then finally, in the lower right-hand portion of the screen, we can see just a heat map of when each of these payers is potentially having some issues. So we can see that Aetna was really struggling to pay appropriately in Q3 of 2019. Blue Shield had some issues they consistently have issues, but they had some major issues in the middle of 2018. And Medicare pretty much is relatively clean here. So looking at that, and then this Medicare graph right here, that tells us 2 things. Number one, that our system is accurate. For those of you that are in the revenue cycle space, you know that Medicare pays pretty accurately. So you shouldn't be getting a lot of underpayments from Medicare. So the fact that our system is showing only $123,000 worth of underpayments compared to $2.5 million worth of underpayments for the other payers shows that our automatically calculated contract rates are accurate. That said, we can see in recent months that Medicare is greatly or has many more underpayments than they did in previous months. So if we wanted to look into those months and Medicare, we can drill in and see what type of procedures are we receiving underpayments for. So we can see on the right-hand side that it's a 99442. So I'm going to click on that just for those that aren't familiar with that procedure code. It is a non-face-to-face physician service. So telehealth, COVID related. Everyone was struggling with that. Just because I know this client's data, I know that the MAC that was paying these services was having issues with this service paying appropriately at first. We can see from the graph for Medicare that the majority of the underpayments have been recovered. And I know this happened naturally. The payer realized their error and then they corrected their payments. Moving on, if we want to take a look at Blue Shield. Blue Shield is a good example of a payer that the organization is working with. So they've had about a 50%, a little over a 50% recovery rate for all of their potential underpayments. We can see that their potential underpayments are still there, but they're going down over time. This organization has been working with Blue Shield, has provided data from our systems, and we have seen results. So the purple line indicates that we're receiving corrected payments. So our underpayment amount is going down for this payer. There's a different story for Aetna. So if we focus in on Aetna here, Aetna has more underpayments than Blue Shield, yet we can see almost no purple line here. 0.4%, or yeah, 0.4% of the underpayments have been recovered for this payer. So again, just because I know the situation behind the scenes here, I know the client has been working with Aetna, they have had meetings with Aetna, and have not turned in any data. It was more of an overview meeting. Aetna and the client determined what the situation was. It was essentially like a credentialing error with individual providers. So the issue stemmed from each individual provider that was getting underpaid. Aetna said that they were going to take care of it and no more data was needed. We can clearly see from our app, since we continually monitor this, that they might have taken care of it, but they certainly didn't repay the amount that they said that they were, or that they would. And Aetna not only owes beyond timely filing, so they owe beyond that 1 year because it was their issue, they also owe interest on this. So it really is in their interest or their best interest to pay this back as soon as possible. So I know our client is currently going back and providing more data, more specific data to Aetna to get this taken care of using our application. If we wanted to continue on and look into that Aetna data or that Aetna issue, we can move on to our provider-related data page. So this page shows you, excuse me, this page shows you some more details. It's not the fanciest looking page, but it really helps us get into the root causes and patterns for these underpayments. We can view the underpayments by classification, so your taxonomy codes, providers, place of service, and a variety of other things. Because I know this Aetna issue was based on providers, I'm going to go ahead and look at Aetna providers. So the charts here show you all of the providers in the system. Again, de-identified, these are not real. It shows you the providers that have the most underpay count. So out of the services that they've provided, this provider has 1,000 services that were underpaid, which is 50% of the services that they rendered. So I'm going to go ahead and take a look at that provider and go back over to the timelines. Again, Aetna told us that they took care of this issue. So we can look at this provider over time. They consistently over the years had underpayment issues. But as we look at recent quarters, so quarter 3 actually has 0 underpays. They're not even on this chart. And quarter 2 of this year only had $280 worth of underpayments. So just looking at that trending, it looks like Aetna did actually take care of the issue for this provider, even though they hadn't repaid it yet. So now I'd like to look at current issues. So we looked at that provider didn't have any issues, but let's actually go over to the provider related data for Aetna. All right. So now I'm looking at 2020 quarter 2. So these are providers that have recent issues with underpayments. So this provider here, she had 72% of her recent services paid as underpayments. So we're going to look into that provider. So going back to the timelines, this provider also had consistent underpayment amounts over the years. It looked like they might have taken care of it in quarter 1, but going to quarter 2, we can very easily see that this provider's issue was not taken care of. So we can grab providers from that most recent quarter, turn those back into Aetna and say, you know, you actually didn't solve that issue that you said you were going to using the data that we found in this application. All right, now moving on to our reporting page. Again, this is a Vizlib extension. This is their custom reporting, which if I can brag about Vizlib for a minute, this is an amazing amazing extension. I absolutely love this one. This extension allows you to create reports on the fly. So we have all of the 837 and 835 data parsed. That data is or can be available in this application. Again, this is demo data. I didn't want to de-identify every field on a 837, so we have limited data in the demo. But all of the fields on the claim and remittance are available in this application. You can create reports on the fly based on what you want to report. That said, just from our experience, we know what providers or what payers typically want from us for appeals data. So we've created a pre-made appeals form based on the data in the system. And from there, you can customize it to your needs. So in this case, we were looking at that one single provider for Aetna. So we can just right-click and export this data. It is all pre-made with that provider's Aetna underpayments and turn that into Aetna and say, you know what, this is not what you actually said you were going to do. We are still getting these. And it has all the information that the payer needs. That said, if the payer comes back and says, you know what, I know we normally ask for these 10 fields, but in this case, we need more. The user can quickly come in here, go through the fields that are available, and add additional items to the report. Let's just add easy ones, modifiers here. They can quickly add the fields. If they wanted to move them around, they can do that and sort and whatnot, and then re-export the report to give to Aetna. So it's a very simple tool that makes a very powerful difference. Does anyone have questions on the Vizlib form or anything that we're doing with this?
Yeah, Melissa, I do have a question. So it seems like you bring in the data at the transaction level. Is that correct?
We are, yes. Mm-hmm.
Okay.
Yeah, we've fully parsed the, yeah.
Okay. And then for a client, let's say the size is Cedars-Sinai,
Mm-hmm.
how much data, how many years can you bring in, and what's the size of an application like this?
They're large. So our other applications have, let's see, 5 years in the one. Yeah, so we have 5 years in one application, and then the other applications, we typically have 3 years worth of their data. The one application has roughly 50 million transactions in it, and then the others probably have 20, 25? Yeah.
Yes.
Yeah. This one is more recent. This is our most recent developed product, and it probably has 3 years worth of data in it right now.
Starting in 2017.
2017? Oh, okay.
Through a tiny bit of Q3 2020.
Awesome, thank you. Yeah, it's tricky. It's a large volume of data, so
Mm-hmm.
performance is always something that we pay attention to.
We do have pretty large servers, yeah.
There's some other questions in the chat there too. I'm not sure if you're able to see them because you're presenting, but is this, you kind of talked about this transaction level, yes.
Mm-hmm.
Do payers ever pay a settlement that is not posted to accounts or transactions? This is
occasionally they do. Our clients have had pretty good success getting the payers to reprocess the claims in bulk and repay them once they've corrected the core issue. But there are times when they will want to do a settlement instead, and it's oftentimes like in this Aetna case, which is based on a real life scenario. They're likely to settle because they don't want to move any patient responsibility. They don't want patients to incur any patient responsibility on old balances or old services because it makes both the payer and the provider look bad. So we've seen it both ways, but for relatively recent underpayments, our clients have had very good success getting the payer to reprocess in bulk as long as we provide them the core data elements to identify those claims in their system.
Perfect. And another question is, you mentioned machine learning in the robotic, little image. Is machine learning used anywhere in this one that you can kind of call out?
Yes, to determine all of the contract rates that we're using. We're not loading. We do have systems where we load contract rates, but this one, we are not taking any contract rates. Our machine learning is determining what the contract rate should be for all of these situations.
Perfect. Note on, useful. Thanks for sharing. Definitely closes gaps in Epic. A little off topic, but a few people have asked this too, like, how are you anonymizing the data? not having.
We've gotten really good. We've gotten really good at using Qlik actually to substitute names and dates and everything. And yeah, it took us a while. This is probably our 10th go round at trying to do this over the years, and this one was pretty successful.
Yeah, Joe and Melissa. Yeah, so this is very important for others to learn actually, because I've approached many people and they were very uncomfortable, obviously showing healthcare data, and so I don't know, perhaps we can have another session just on tricks on how to do that, right?
Yeah.
And so,
for just a quick one, mapping loads, we do a ton of mapping loads to replace things.
Oh, nice.
Yeah.
Awesome.
Yeah, and then save the QVD so it doesn't take 10 years to load every time.
Yes. Another one was the extension name on the appeals data table. That's the custom report.
Yeah.
Nearly everything people have shown. This is not a commercial for Vizlib, but if you ever want to try this stuff out, it's free for up to 5 users. And so I really like this one for replacing reports that people come to. And when you have apps that have tons of different tables, usually it means, they're going to have different questions, and that you're just going to get another request for another table in your application. So this just gives your users that ability to ask their own questions really quickly. And it works with LS Analyzer licenses. So you see, Melissa doesn't have to hit edit to create a new report or have a new view of things. And I think that saves a lot of people time and then resources as well.
I'll say, Joe, it's our most heavily utilized feature in our analytics applications, just for that very reason. It saves a query, it saves a report request. We just load as much relevant data as we can to keep a quickly moving application, but then let people determine what they need to bring out of the system. And I'm not being paid to say this. Our clients just love it. We actually try to get them to go to our visualizations page more and use them because they're useful. They just love custom reporting.
Did I miss any from up above? I guess, thanks again for showing what you have here. I know we're right at the point where we said we'd wrap the call, but if other questions are coming on, I can stay on for a little bit. Others may need to drop, but I guess for the current speakers, thank you so much. And if you're up for it, I'd be happy to share your contact information if people have additional questions. Or you can just have them go through me or Claudia and we'll route them to you too. It's up to you. Just so you don't get 200 emails in your inbox tomorrow for the, share that again.
Yeah.
But again, thank you so much. And thanks for people from other time zones jumping into getting up early or staying up very late. That's great. Thank you.
Thanks, everyone. Bye now.
Yeah. Thank you.
Thank you.
Bye.
Sounds good. All right. Thanks, everybody.
Thank you.
Bye, guys.
Take care. Bye-bye. Thanks, Claudia.
Oh, you're welcome.